Okay, good afternoon, good night, everybody. Thank you so much for being here to the very important session of the 8th edition of the Critical Lung. It's dedicated this session to the practical aspect of advanced mechanical ventilation. As we all know, despite the strategies of mechanic protective ventilation to decrease tidal volume and inspiration, the mortality of patients with ARDS is hasn't been decreasing. So we want to strengthen some measures to increase survival. So in this session, we're going to have 3 talks about identification of asynchronies, and we have 3 experts in these topics. We are sure that they're going to be fruitful and have valuable knowledge. First, Dr. Jaime Retamal. He is professor of the Department of Intensive Medicine of Universidad Católica de Chile. Then Dr. Alejandro Bruhn. He is the chief of Department of ICU and professor of the School of Medicine of in Chile. Sorry, the audio is a little bit interrupted. So we are going to be starting. Jaime, welcome. Go ahead. Thank you, Manuel. Okay. Good afternoon, everybody. Now we will speak about mechanical power and how to improve the ARDS in the clinical practice. And these are the topics that we are going to cover. So in 15 minutes, we will speak about definitions and some physical and physiological determinants. We're going to speak about the concepts and the problems that we might have and some final messages. According to our objectives, this is going to be a very short presentation and be able to define these issues. We cannot speak about mechanical power if we don't speak about villi. This entity is lung damage associated to mechanical ventilation. In these elements that influence villi, we see it in the flow chart. We try to measure in mechanical power, pressure, volume, flow, respiratory rate, and there are other variables that are proper of the patient's lung. That is the size of the functional, the presence or not of lung edema, the early stage or late stage, the alveolar stability, the overdistension, the stress razors, that among other factors, they could modulate the effect of the ventilation on villi. There are other factors like temperature, vascular flow, pH, inflammation, and others. It is very interesting, and one of the things that we should ask ourselves when we work with mechanical power, that there are some direct variables to villi, like flow, respiratory rate, but there are other variables that have like 2 phases. PEEP, for example, It could increase the mechanical load, but on the other hand, it could modify the variables dependent on the patient, reducing different phenomena. So, to explain this phenomenon linearly is not easy. We have to, of course, analyze several variables. The respiratory rate could multiply the damage, but it also can reduce and reduction of the collapse at the end of inspiration. So it's a complex phenomena, and there are several factors that influence it. There is no absolute number. What is mechanical power? It's the intensity in which the mechanical respirator supplies energy to the lungs. This is the classical graph, and it integrates the curve, pressure, and volume. And this includes the elastic potential energy and the dissipated energy. It is divided in these two components. The elastic energy is without producing an impact in the patient. Tidal volume, for example, since we are born until we die, this energy is spent. It doesn't produce a physical change in the lung, and it allows it to behave in an elastic way without having any changes. And we have dissipated energy. That is when we overcome certain energy margins. And here we do have damage, heat, tissue damage, that would be villi, and this produces the damage. How can we analyze this complex phenomena and work in energy is the change of pressure and the change of volume. And if we uh, put it in the clinical settings, is the equation of motion that we see in the slide, including the PEEP. These components of this equation can be divided in an elastic component, dynamic component, and static component. In 2016, they proposed this formula to analyze the mechanical power. It looks a bit complex, but really it is not so complex. Pressure times volume. And something interesting that many of us were very happy when we saw this in 2016 was to multiply this absolute value of the change of pressure and volume for each ventilation times respiratory rate. And then we would have this in order to time. So we're speaking about energy, joules, and we are speaking by minute. What was demonstrated in this study? Here we see the plot of a broad database that they had with 5 and 15 of people. It is a very close graph. We see the equation and the plotted points according to the curve of pressure and flow. The different elements evaluated in this equation of mechanical power could influence in the change in different ways. He proposed that tidal volume and having a more intense change of 30% in mechanical power and up to 30%. Later, we were able to have this work of Cresoni, and this was an experimental model. Here, we see the whole lung edema, one field edema, isolated densities, and baseline. In this case, what they conclude is that the lung, just like any other structure, has a resistance to certain energy. We know, for example, that a building can tolerate a certain movement, like in an earthquake. That's also how the lung can tolerate energy. But when we have this limit and it is it is too much energy, then there is damage to the lung. Then later, this retrospective review of two very large databases and shows and speaks about the prognosis. For example, they analyzed mortality, ICU, but it also showed that there is a threshold. Here we see first day and second day. However, and this is very logic, the absolute value of mechanical power cannot be applied globally to all of our patients. It's not the same to, for example, produce the damage. So, according to the energy and to the size of the impact, the damage can be larger or smaller. So, in 2020, it's 220 retrospective study of and the mechanical power absolute or measured according to the transpulmonary pressure, the mechanical power was adjusted to the compliance. And we see the association to mortality. Recently, a group from Sao Paulo also did a retrospective analysis of 4,000 patients. Of different studies, RCTs, that had been published earlier. And here we see the variables and the tested predictors. They were both comparable in mortality, and the mechanical power was an independent variable. And the driving pressure is one of the variables in the equation that has the strongest impact in the correlation with the outcome. And we see the higher impact in mortality. And we see the tested predictors, the single ventilatory variables, the total power. Why can we, if we analyze what has been published, there is not an uniformity to speak about the prognosis of mechanical power? Well, first, because the equations are not the same. There are simple things. For example, the value of PEEP was inside the value multiplied by respiratory rate. Over here, the PEEP is in a different equation. Also, this other formula is a little bit more simple. So according to the tool, we will have different results. We measure we measure the mechanical power, and we are integrating all of the features of the lung. If I have an absolute value that includes all these determinants, I do not know exactly how each one of them is influencing the final result. In the 70s, and other studies have confirmed this, that heterogeneity increases. So the effect of mechanical power has to do greater or less. If it's a baby lung and if it's an absolute value size. So here we see the effect of the parenchymal on the parenchymal tissue as final messages. We can say that MP is a parameter that comes from the equation or the formula of movement, which is an analogous to the energy used to breathe by unit of time. It integrates different components of the lung, and different features could be explained because of this. Basically, because of the differences in the formulas used, the measurements also are in different times, and the indexation by size. Usually, they are done by size, etc. The heterogeneity, the content of edema, and the evolution of the respiratory distress can also influence, and the influence of the chest wall versus the size of the lung. And finally, we have to determine if this parameter in any controlled study could demonstrate any effect. But it can be a safety threshold versus a severity marker. Thank you for your attention. I will be available for questions. Thank you, Jaime. Now, Dr. Alejandro Bloom.
All right, wonderful. Excellent. Thank you. Thank you very much. Thank you very much for the invitation. In the next 15 minutes, I will be discussing a little bit about driving pressure. I will also try to approach this question on whether this is a risk factor or if maybe it's a clinical target in itself during mechanical ventilation, especially in ARDS patients. However, I believe it can also be relevant in other environments. We will have the discussion. So first, we would like to go over a couple physiological concepts related to this concept of driving pressure. And then the clinical correlation, meaning that there is a lot of clinical relevance and some ideas as to how we could integrate it into our protective ventilation strategies and other forms of clinical treatment. So for a couple of decades already, protective ventilation was proposed since this article that you see here. And basically we use low current volumes to do that. The concept took a while to penetrate, but in the end, thanks to this paper, the question was settled that effectively a low current volume is an essential element of protective ventilation. And this type of ventilation plays an essential role in lung protection. Now, the way in which we approach the titration of current volume in this strategy for 6 ml per kilo of ideal weight in protective ventilation, we find that the only necessary action is to titrate it to the size of the individual. And we could draw a parallel to the size of their lungs. However, this is the size of the lung under normal conditions. So we are engaging in some form of personalization or customization, determining the normal ideal volume of that person's lungs. However, persons with ARDS can be highly variable, and we have different possible results in scans. And we observe how the functional size of these lungs actually varies quite a bit. Therefore, that personalization, the size of the individual, not the lungs, or rather the volume of their healthy lungs, at least in theory, is very far removed from what we see right here, contrary to what we've seen in lungs with some remaining recruitment. And we also see other limitations for current volumes. In so many words, we're applying a very one-size-fits-all approach, very clear medical formula to do this. And much like Jaime was saying, driving pressure has garnered more and more attention for the past years, especially after Dr. Amato's publication almost 10 years ago. So driving pressure is only the pressure differential during controlled ventilation between maximum inspiration pressure or plateau pressure, which represents the end of expiration pressure, and the PEEP, which refers to the positive pressure at the end of the expiration, i.e., the pressure in the alveoli at the end of expiration. When we talk about driving pressure, in one way or another, we're talking about the pressure that drives air into the alveoli, into the lung unit. Of course, this is very closely related to current volume. That is rather obvious. It is very clear. Here we see the curve of a patient at 12 ml per kilogram of ideal weight. And indeed, in parallel, this driving pressure is also reduced significantly. And the Armegal study also showed the same results as we saw at the start of the presentation. So both elements are very closely related. But we could also see that driving pressure can give some additional information. The way we find this correlation is basically the compliance of the respiratory system. It has to do with the elasticity or the elastic features of the respiratory apparatus, which is quite interesting. So volume and driving pressure are mathematically correlated, except for the compliance of the respiratory system. It's quite an interesting idea, but this compliance of the respiratory system is very closely related to something we mentioned before, the functional size of the lungs in place for that. And it has to do with the concept of bilingual, as we described in prior decades, as well as the damage induced by mechanical ventilation. Now, it is true that when we first started doing scanner images of the lungs, we found that these patients would show a significant reduction of a functional lung volume, pulmonary volume, meaning that the availability of alveoli was reduced in some of the more extreme patients. In some scanners, it was very drastic. And in other patients, it was not as drastic. It was quite heterogeneous. It was very variable. And so this is what we were able to find in that study, that a percentage of the lung that would remain ventilated, well, the scanner had to be assessed constitutively, and it had a very similar curve to the compliance. So when we say that there's a decrease in compliance of the respiratory apparatus, in one way or another, the magnitude of that reduction is related to the baby-line ratio in this patient. There's a very tight relationship. The lower the compliance, we can assume that lung compromise is greater and that the units available for respiration are reduced. So I have a clearly defined mathematical relationship in which we see that the driving pressure is very closely related to current volume, and that has a very strong correlation. And that compliance of the respiratory system is very tightly connected to the concept of valent. So again, the driving pressure in one way or another is a way to correct current volume, not only in accordance with respiratory apparatus compliance, but also the size of the lung. And therefore, it is when we introduce the notion of a driving pressure, we can customize, we can personalize current volume as per according to the number of pulmonary units available for ventilation, which makes a lot more physiological sense compared to the cross-cutting recipe of just applying it generally. It's pretty logical in that sense. On the other hand, another important concept is that driving pressure associated with a very important concept, and that is the cyclical strain strain, yes. By strain, we mean deformation of the lung. And when we talk about global strain, which we apply in the lung, well, whenever we apply a positive pressure, we are applying a form of deformation. PEEP will induce lung deformation. Now, PEEP is continuous during the entire respiratory cycle, so we have continuous or static strain. But upon that, we'll find tidal ventilation, and of course, that tidal ventilation events will generate a second instance of that is dynamic and cyclical around the respiratory cycle. So, the driving pressure will have a tight association with the magnitude of this deformation. And this deformation has to do, when we talk about lungs broadly, between the relationship between current volume that we introduce into the respiratory system and the functional reserve, i.e., the amount of change that we see in volume per every respiratory cycle. So the driving pressure has both of them. First, you have the personalization according to the functional size of the lung, and on the other hand, a measurement of the strain of dynamic strain. This is essentially what builds up the idea and the concept of protective ventilation. So, bearing all of that in mind, as Dr. Amato was researching, for a long time, he investigated the role that driving pressure could have, and particularly of current volume management. So, after a lot of analysis, collecting data from several multicentric studies and randomized controlled trials with different ventilation strategies and some very sophisticated analysis, they were able to determine that the driving pressure was very closely related with the risk of death for patients once you make adjustments or correct on all other ventilation variables. So on the left, we'll see how there is an independent relationship between the driver pressure, which is separated, and it leaves patients from lower to greater pressure, and the correction for the relative risk of death. We see that there is a more or less linear relationship. Now, the threshold is not all that clear, but we see that now we see to start increases and acceleration in the pace and the risk of death. Now, let's look at the right on the graph. Here is a breakdown of the patients in quintiles according to different criteria. So in the first case, they were separated into 5 different quintiles, where all 5 groups had the same PEEP values, but different levels of driving pressures. And on the bottom, when we look at what happened with the relative risk of death, we see a very linear relationship. Again, also with PEEP, but the greater the driving pressure, the greater the risk of death. And when we do a second analysis and now we pair them on 5 different quintiles, we see that all 5 groups will have the same levels of driving pressures, and clearly there is no change in mortality, meaning that there's no independent relationship between PEEP and mortality as opposed to driving pressure and mortality. Now, a third analysis broke out the 5 quintiles, that is, taking all of these to the plateau levels, and the analysis of driving pressure versus PEEP. And now we see an inverted relationship in which we see that those with greater driving pressures had a great level of driving pressure, have a greater level of mortality. But the most important independent factor is not current volume. It is actually the driving pressure. But again, this is a statistical analysis done with data from other studies. It does not correspond to a study where we study driving pressure. It's just a relationship between variables and outcomes. But this concept has also been refuted in many other analyses that have confirmed the predictive value of driving pressure. For example, this is an analysis that combined the results of the neuromuscular trials in France in proposition. They took the patients from that study and looked at driving pressures on the day one, and they did a breakdown according to the driving pressures that were greater than 13 centimeters of water. So we see a very clear correlation in overall survival. Here we have the Lancet study, including thousands of patients with ARDS, the cutoff point at 14 centimeters of water. And again, we notice this very clear difference with a very obvious predictive role. This was very famous in the world of anesthesia, where there was a series of studies ensued trying to compare different PEEP management strategies during anesthesia. These patients had risk of complications in the perioperative period. Here they combined more than 10 of these studies, and they observed what happened with the driving pressure according to the PEEP adjustment determined by randomization. As stated, they also found that in those patients in which the change in PEEP generated an increase of the driving pressure, it actually resulted in excess or mortality, whereas the change in mortality in any other patients actually had a lower risk of death, suggesting that not only would this work as a predictive factor, but in one way or another, it would be the result of a PEEP upon the driving pressure, and it could determine how this change in PEEP could have an effect on mortality. And here we have the ARDS study, and trying to optimize the driving pressure together with the recruitment strategy, it could also result in a better outcome. This was a study done in Latin America, especially in Brazil, with the open-mind approach strategy versus the conventional protective strategy, titrating PEEP versus an FiO2 table. Indeed, it managed to achieve recruitment in this group, and in fact, they had a series of events where there were a decrease of driving pressure up to 8 centimeters of water, and 16 versus 12. But what happened with mortality? We had this paradoxical effect in which, in spite of achieving a decrease in the driving pressure, mortality increased and it did not go down. So conclusions are that it is true that we can't be reductive in our thinking and consider that all risks from mechanical ventilation during ventilation can be reduced to a single parameter and just do mechanical power driving pressure. There are other considerations. In the case of this particular study, it is estimated that the strategy of PEEP and recruitment maneuvers were too aggressive and causing hemodynamic repercussions on the right ventricle. And also, decreasing the driving pressure had adverse effects. So that's an important conclusion, meaning that we don't have a single parameter that can answer all questions. We have to make a more complex and more subtle analysis to determine whether driving pressure is the main variable we should consider in titration of mechanical ventilation. So what to do in practice? Well, obviously, we want to protect as much as possible. We do protect ventilation as much as possible. This could be reduced to the reduction of driving pressure, and reduced strain induced by mechanical ventilation. In theory, yes, the more you decrease the current volume, you will reduce dynamic strain, and we will also decrease transpulmonary pressure. But of course, the question remains: what's going to happen with alveolar CO2 pressure? We can also have issues such as atelectasis if we didn't use an elevated PEEP. And therefore, of course, we need to achieve a balance there. What can we do in practice? Well, we ventilated the patient at 8 milliliters per kilograms of ideal body weight. If we have a driving pressure at 10 centimeters, this should indicate that we're doing okay. And if these 8 millimoles per kilo are doing the right job, if they're doing the job on alveolar ventilation and allowing a proper aeration ventilation of the lung without association to progressive collapse, then we can rest easy. But what could happen here? Well, it could be not protected because we have a driving pressure of 20 centimeters of water. Here we have a pressure. Here we have a patient with reduced compliance, and we don't have easy answers here. But definitely we need to take this into consideration. Those 20 centimeters of water should open up a series of questions. What is behind this minor compliance? Do we have an extra thoracic issue? As to, for example, with intra-abdominal pressure, you have an issue with the lung parenchyma, or do we have an extremity then? Or we're starting with an autoproliferative session. We could use imaging studies to see whether there is a new interstitial atrophy or some level of pulmonary consolidation. Obviously, we have more advanced studies such as bronchoscopy or even biopsy. And so, yes, some have proposed that in such cases, we could propose extracorporeal therapy to try and do ultraprotective measures so that there is a more simple driving pressure. This is an idea that makes a lot of sense, but here we have the REST study using extracorporeal circulation in patients with low CO2 with severe distress. And in this second group, indeed, current volume was able to decrease up until 4 mLs per kilo. And here you see the breakdown of days 1 through 5. And we see that pressure was successfully decreased compared to the control group. So, again, overall survival rates were more or less the same compared to the group in extracorporeal pumps. Obviously, responses don't necessarily go in that sense. If we lay all our eggs in the same basket, we will not necessarily see the results that we expect. So once again, we don't have any easy answers. This doesn't mean, however, that we're not going to look at the parameter. But what should we do with it? Well, it's very likely that we have to make a more subtle and complex analysis. So driving pressures adjusted for compliance of the respiratory system. It is closely associated to the notion of cyclic strain. It is very clear that it is a strong predictive factor, has been constantly associated with worsened outcomes, and that is quite obvious in terms of compliance. The worse the compliance, the worse the outcomes as well. But it's very important to keep in mind that this has never been used, it has never been tested in large RCTs with the objective of looking at a primary endpoint of mechanical ventilation. We have not tried low ventilation, low pressure, or low current volume ventilation strategies versus other parameters. We have no evidence to say that if we titrate ventilation with this parameter alone, will be effective and safe, at least with the levels of effectiveness and safety that we seek to find. And therefore, we would recommend, and we do include this in a review that we developed together with Guillermo Gil and Guillermo Alamar, we suggest using as only as an additional safety limit for protective ventilation, together with hemodynamics, with plateau pressure, the right ventricle, and that would be the best approach to define a strategy for protective mechanical ventilation in our patients. Thank you very much. Alejandro, thank you. We will now have Dr. Gaston Murias.
Good afternoon. Thank you for the invitation. And during these 15 minutes, I will try to summarize a very complex topic, the dyssynchrony patient ventilator, and trying to present a sort of taxonomy of those asynchronies. The way we understand respiratory mechanics, besides the equation of the respiratory mechanics, the ARDS has tried to show the respiratory mechanics, and it has been particularly useful so that we understood the load, the resistive and the elastic loads that the ventilatory system was used to during ventilation. However, when the equation of moving wants to be used in a scenario where it's no longer a pump but 2 pumps, because we have the respirator and the respiratory muscles of the patient during partial ventilatory support, then things become complicated and it's much more difficult to understand what is happening. That is why I will propose a change in this paradigm, how we will see the respiratory mechanics. And I will propose that to these volumes that corresponded to the total PEEP, the volume and the unbalance generated in the airway to generate flow, we transform that into a single volume each. This might seem semantical, but I will try to show you that it is not. When you integrate all of the volumes over the functional residual capacity at the alveoli level, the alveolar pressure is equal to that volume over the functional residual capacity multiplied by the elastance of the peripheral compartment of the pulmonary parenchyma. And when you unify all of the volumes in the airway, you can define that the pressure in the airway represents the volume of gas lodged in the airway by the elastance in the airway that is different than the elastance in the pulmonary parenchyma. Well, and we can calculate this, but we want rather a conceptual approximation. What we understand from this is that every time the volume of gas changes, the pressure will change. So understanding the determinants of the volume lodged in the airway will make us be able to understand what these two pumps are doing, interacting between each other. This compartment has a central compartment representing the airway, and a peripheral compartment that represents the pulmonary parenchyma. Calling it central or peripheral, the peripheral one fills and empties from the central component. So the pressure in the airway will depend on the interaction between these two pumps. One pump that is the respirator that is adding gas from the atmosphere during inspiratory time, and another pump, which are the patient muscles that are redistributing that gas towards the peripheral compartment, taking it out of the airway, taking it out of the central compartment, and taking it to the peripheral compartment. And this is seen this way, controlled by volume, for example. And this is what we know as flow desynchrony. When we don't have an adequate match between the flow of the respirator and the flow that the patient is taking out, and the respirator is not able to pressurize the airway adequately, then we have that flow desynchrony that implies one of the two main mechanisms, the global mechanisms of desynchrony. The effect of inspiratory muscles, the redistribution of flow, is this. It is the redistribution of the gas, take it out of the central compartment, take it to the peripheral compartment. And even when you don't reduce the total volume of gas that is lodged in the system, the pressures will necessarily have to fall. The other big chapter of desynchronies are related to the phase desynchrony. From the moment we're born until we die, we're in inspiratory or expiratory moments. And the same thing happens with the respirator from the moment that is turned on until it is turned off. We speak of phase desynchrony when the start or the ends don't coincide, or the inspiratory times of the machine or the patient, when they don't match the beginnings of the inspiratory times. We talk about initial desynchrony, and when the ends of the inspiratory times, we talk about terminal desynchrony. So there are four scenarios that have been established. Terminal desynchrony, where the patient can end before the machine or can end after the machine, and two scenarios of initial desynchrony, where the patient can begin before or can begin after the machine. And we will analyze each one of these scenarios in mechanical terms to try to understand the desynchrony mechanisms that we see every day at the bedside of the patient. What happens when the patient ends before? We breathe in a quasi-sinusoid that goes from inspiration to expiration, and we hope not to have a respiratory pause in the middle. That means that after the inspiration ends, our respiratory center waits or expects to be able to exhale without any problem. Now, if the patient ends before its inspiratory time, then the machine's inspiratory time, the consequence is that when the patient tries to exhale, the central compartment, the airway, is still being pressured by the respirator. So what does the patient have to do to expire so that the peripheral pressure exceeds the pressure in the central compartment? How do they do it? Well, activates the expiratory muscles. And this is something that is seen very frequently in obstructive patients, that are patients where there's autopeep very frequently. And these obstructive patients that try to breathe however they can in reality and that have usually very short inspiratory times, trying to prolong that inspiration are patients in whom the inspiratory time of the machine very frequently is prolonged, either because it has been set or because it has been set a level of support that is very high, and the inspiratory time of the machine invades the expiratory time of the respirator. And here, this old graph of work of Patasarati that is very well known, what we can see is a spike controlled by pressure that should not be there, tele-inspiratory spike that coincides with 50% of the inspiratory time of the machine, approximately, where the patient is activating the expiratory muscles. Now, it's the two pumps, the ones that are putting gas into the central compartment, and this determines an increase in the pressure in the airway. And this is very common to see in support pressure, very common to see in real traces of patients. And when we see this tele-inspiratory peak, one should suspect that the patient is incurring in this type of problem. Obviously, we don't have to look at the curves of a respirator to know whether the patient has active inspiration or not. But this can give us a clue on what are the mechanisms why this is occurring. What happens when the patient ends later? If the patient ends after the machine, the patient continues inspirating when the machine has closed the inspiratory valve. The natural consequence of this is very obvious. The pressure in the airway falls again. If it falls enough, this is going to generate a double trigger of the respirator. This is a double inspiratory time without being separated by an expiratory time, separated by an exhalation, both in control volume as in control pressure. The inspiratory time is doubled, in control volume is also, and the tidal volume is also doubled because there's one inspiration over another without expiration in the middle. Well, in terms of tidal volume, it's not as serious. In controlled pressure, because the patient stops its control, the pressure gradients end that explain the inspiratory flow. But the double trigger is a consequence of a patient that ends its inspiratory time beyond the inspiratory time of the machine, when the machine has already closed the inspiratory valve. Now, the phenomenon is not this magnitude. So as after the inspiration ends to trigger the respirator, we see the same qualitative phenomenon, even if quantitatively it's different, which is the inspiratory flow, which marked with the black arrow. This amputation of the peak is explained better, understanding why the inspiratory peak occurs. This peak of expiratory flow occurs because when the patient relaxes the inspiratory muscles, the elastic retrocess takes it to the maximum point at the end of inspiration, let's say at the beginning of exhalation. And since the flow is equal to the difference in pressure over the resistance, this generates a peak of expiratory flow. Now, if the inspiratory effort of the patient is prolonged inside the expiratory time of the machine, there's this amputation of the inspiratory flow peak because the persistence of the activation of the inspiratory muscles of the patient avoid that peak of pressure, of that transsystem pressure generated by the normal relaxation. Why does this happen? It might not be a problem in itself, as Alejandro Bruhn was explaining, but it is important. We're getting involved in a scenario that is complex, where the tidal volume that has been the tool that we have used historically to protect the lung, the reduction of the tidal volume, well, here evidently we're having two tidal volumes that are added up, and this doesn't seem to be severe. The amputation of this inspiratory peak is not as severe. However, as you can see here, and this is a real trace of a real patient, this phenomenon, and this one over here occur in the same trace at different moments. When one is seeing this phenomenon, we have to be very careful, because a little bit before or a little bit later, the double trigger might appear, and then things do become complicated. remember that the difference between the amputation of the expiratory peak and the double trigger is quantitative and not qualitative. And you can see that in a diaphragmatic image. If the patient is connected to a respirator, that measures the diaphragmatic electromyogram, and the inspiratory time of the machine ends at this point. The inspiratory time of the patient is prolonged beyond this, and you amputate the expiratory flow peak in the curves of this trace. Now, why could the patient begin before the machine? To understand this, let's go to the bicompartment model and let's understand what the patient does to be able to trigger the respirator. The patient cannot modify the pressure of the airway which is what the machine is monitoring. What the patient can do is modify with the inspiratory shows the size of the peripheral compartment. The patient can increase the patency of the chest, the volume of the chest, and with this, at the volume of the quantum of a pulmonary parenchyma, can reduce the pressure. This fall in the pressure in the peripheral compartment, this fall of the alveolar pressure generates a gradient of pressure between the central and the peripheral compartment. A part of the gas lodged in the central compartment goes through the peripheral compartment in favor of that pressure gradient. And now the volume of gas is reduced in the central compartment. And this reduction of the volume of gas or the pressure is a signal that the respirator has to shoot. Now, this is what happens in normal conditions. Now, what happens if the patient begins its inspiratory effort when it still hasn't reached the functional residual capacity? What happens, in other words, if the patient has autopeep? If the patient has autopeep, the first part of the respiratory work of the patient has to be used to beat the elastic load. And when the moment was able to equalize the pressures between the central compartment and the peripheral compartment, if it continues with effort, if it persists in its attempt to trigger the respirator, this gradient of pressure will be generated. A part of the gas will come out. It will go through the peripheral compartment, producing the trigger of the respirator. Now, it could also be that the inspiratory effort of the patient could not be of enough magnitude to achieve this. And when this happens, we have the ineffective inspiratory efforts. So the patient gives up in its inspiratory effort before triggering the respirator. Naturally, this is not expectable. It's not seen in the airway pressure curve. It's marked in black in this trace. And it's not expectable to see it because since the volume of gas was not reduced, the pressure of the airway is constant. However, what it has done, this inspiratory effort of the patient, is to produce a fall in the pressure from the peripheral compartment. Once again, since the gradient of pressure between the central compartment and peripheral compartment is the one that determines the expiratory flow, the sudden reduction of the pressure in the peripheral compartment leads to a sudden reduction of this pressure gradient that is seen in the expiratory flow curve as an indentation of these characteristics. And the ineffective inspiratory efforts are not a problem themselves. These ineffective ones are not another thing than a symptom that the patient has autopeep. And if we have to reduce these ineffective efforts, we reduce the autopeeps of the patient with any of the strategies that we know that are available for this. Reduce the support pressure, increase the cycling off in a patient in support pressure, prolong the inspiratory time. The measures that we know to be able to use a bronchodilator treatment. The measures that we know to reduce autopeep are the ones that are going to reduce the ineffective inspiratory efforts. And the counterpart is true. When a patient, we increase the support pressure, we expect that the ventilatory pattern somehow becomes a slower and deeper pattern. And we have to be careful with this because what could be occurring is that the patient is breathing more comfortably. But what also could be happening is that we have an artificial reduction of the respiratory rate that we see on the equipment because we have more episodes of ineffective respiratory efforts as we increase the support pressure and we generate hyperinsufflation. To end, what happens when the patient begins out later or afterwards? when the patient begins after. Why does the patient begin afterwards? This is a tremendously common phenomenon of the asynchrony. Up until 2013, that Vangeli Komianaki publishes this in a case that he presents. This was a mechanism that used to be transparent. We had never seen it, and however, it appeared every day, because now we see it every day when we go sit by the bedside of a patient. These are old works. The original works that show this are from the 80s, from the last century. But it did not come from the lab works until Evangelia Komianaki from the group, from her group, shows this. Passive insufflation of the chest has a distension of the pulmonary parenchyma as of the chest box, and that generates a reflex arch, and it shoots the respirator. The respirator is the one that triggers the patient. And so we have a new mechanism of asynchrony. The patient is starting after the respirator. It is highly probable that he will also end after the respirator, and naturally they will start to combine the asynchrony mechanism, because if he starts later and ends later, this is also possible to generate double triggers. In this series, this large series that we published a couple of years ago, a third of the double triggers responded to this mechanism. A third of the double triggers were unchained by a reverse trigger phenomenon. And we know that because the first cycle of the 2 cycles was a control trigger triggered by the machine and not by the patient. So in definitive, this is the classification that I'm proposing of asynchrony. This asynchrony is divided into flow asynchrony and phase asynchrony. And before these 4 scenarios, we have the 4 common mechanisms of asynchrony: active aspiration by the patient, the active inspiratory effort, the double trigger in the case that the patient ends afterwards, the ineffective triggers if the patient begins before, and this does not generate an ineffective trigger, and the reverse trigger in case the patient begins after the machine. Thank you very much. Okay, thank you very much, Gaston. Excellent information. Jaime, Alejandro, and Gaston didn't give us enough time, so I'm going to choose a single question because we have the next session coming up. We have a question that Kelvin Adana asks from Venezuela. Maintaining a driving pressure as a goal, is it directly proportional to controlling the mechanical power, or are these variables that are not related? Please, if we can answer this single question. Whoever wants to answer it. Thank you. Well, I think these are variables that are completely related. The question is if we're looking for this as a goal, as we mentioned before, or as a safety threshold. I think that to date, to have a mechanical power goal so as to breathe safely is a little bit far from what we're doing to be able to have absolute figures. As a general context, I think that it could give shape to what we're doing, but it wouldn't be an objective in itself. Now, there probably are more data, as Alejandro was saying. These are retrospective data generated from the study that they designed to answer another question. But even so, we have a little bit more support to say, let's try to not exceed a pressure that does not go beyond 15. I think that would be like a goal with a little bit more certainty. But even so, we still need data to be able to say that with absolute certainty. I don't know, Alejandro, would you like to add anything else? Yes, I would add. I don't know if I understood the question correctly, but the 2 parameters are very closely related. And the mechanical power, amongst one of its important variables, includes the driving pressure. Basically, the driving pressure is a good part of the energy of every respiratory cycle. So the mechanical power adds a respiratory rate and some flow and volume variables, but the driving pressure naturally is one of the important factors in the mechanical power. 30, 40, 50% of the final result of that mechanical power, but the driving pressure does not have the respiratory rate. The respiratory rate, in any case, there are studies that have associated to the outcome, but its role is more controversial. But of all the variables that include the mechanical power, the tidal volume and the pressure have more support, but the rate still has questions on the role. And the last couple of minutes for Gaston for a question. The non-identification and the non-management of asynchronies negatively affects the survival of a ventilated patient. We don't know. There's some work, there's a series of hours where asynchronies are associated to mortality, a large series of more than 9 million respirations, 7,000 hours of mechanical ventilation, 24 hours of follow-up of 50 patients during all the time of mechanical ventilation, and they're associated with mortality. Now, this is not the way of demonstrating a causal relationship, because the fact that they're associated to mortality does not mean that they are the cause of death. They could simply be markers of severity of these patients, and that the more severe patients have more asynchrony and die more because they're more severe, not because they have more asynchrony. The way of showing this would be with controlled clinical trials where we control asynchronies, and in others we do not control those asynchronies. Now, there are some issues, such as the old story that there's no clinical trial to demonstrate that parachutes save people when they fall from a plane. I think that there are some things that are going to be very difficult to conduct. It will be very difficult to do this, like it is very difficult to show that raising the inspirated pressure of a hypoxemic patient is difficult. Who would not control a asynchrony if they identify it? Who would not attempt to solve the problem if they identify it? So I think this will remain in the theoretical arena. There's a rationale that says that it is probably so. It says that patients have less diaphragmatic lesion and less pulmonary lesion if they have less asynchrony. But there's no strong evidence that somebody could say that we need to control asynchronies because this reduces mortality, which puts things in relative terms. What is the price we're willing to pay? Because as Alejandra was saying, when we decide to ventilate with low driving pressure, there are also prices to this. What is the price we're willing to pay to control asynchrony, and up to where is it worth paying that? That's something we still don't know. If to control a reverse trigger, we have to deeply relax patients, well, probably we're not, there's no business in this. There's no doing this. So I suggest this precisely because every decision that we make in managing critical patients is a balance between risks and benefits. And controlling asynchronies also has risks. It also implies problems, not only problems in asynchrony, but also our mechanisms to solve them. That also implies a problem. If this is about modifying the flow, it's one thing. If this is about deeply relaxing patients, sedating them, or give them analgesia to avoid asynchrony, I no longer know if we're doing anything or not. Okay, thank you very much. On behalf of the organizing committee, I have information that we have more than 400 people watching us live. Good evening, thank you, and goodbye.